The best clue that the splenic flexure has been reached is when the scope emerges from the fluid-filled descending colon into air-filled and usually triangular transverse colon. The splenic flexure can be pushed up remarkably high against the diaphragm in some patients, resulting in shoulder-tip pain. Usually the splenic flexure is a fixed halfway point for the endoscopist. The endoscope can then be straightened back to only around 50 centimeters from the anus because it's tethered to the diaphragm by the phrenicocholic ligament. But the splenic flexure can also sometimes be pulled down a remarkably long way to about 40 centimeters from the anus if this phrenicocholic ligament is free. Paradoxically, a mobile splenic flexure, which makes things easy for the surgeon because it lifts out without dissection, is difficult for the endoscopist because the mobility means there's no control over the transverse. Normally, the splenic is a fixed point which acts as a fulcrum, allowing the colonoscope to lift up the transverse colon by a cantilever effect when the colonoscope is pulled back and straightened. Gravity can also have a useful role in changing the configuration of the splenic flexure. In the usual left lateral position, the transverse sags down, making an acute angle at the flexure, which can be difficult to pass and fluid-filled. Changing the patient to right lateral makes the transverse pull the splenic into an easy bend, often with no obvious flexure at all, while having the patient on the back has partial effect, but isn't as effective as the right lateral position. Passing the splenic flexure needs a 6-point plan of action, keeping position change as an extra in case the combination doesn't work. Pull back the shaft to around 50 centimeters, usually with clockwise torque, until there's a catapult-like resistance on the shaft or slippage of the tip. Deangulate the tip a little. This avoids overangulation into the walking stick handle shape, which tends to impact into the flexure rather than sliding around. Deflate the colon a little to keep it as supple, short and adaptable as possible. Consider hand pressure over the lower abdomen to resist any sigmoid looping. Torque the shaft clockwise to put torsional straightening force onto the sigmoid loop as it spirals to the descending, but adjust the angulation controls to keep the lumen view. Finally, push in, but very slowly, giving the stiff leading part of the shaft time to slide around the flexure. Pushing too fast tends only to force up the sigmoid loop. Stiffening a variable scope at the splenic will usually prevent this looping. If the combination of actions doesn't work first time, pull back and try again. Then try again with the patient on the back, before finally changing position to the right side. With patience and these combined manoeuvres, we can always get the scope to pass straight round the splenic flexure. A reversed splenic flexure occurs when the descending colon is completely mobile on a mesocolon, allowing the scope to push up in the midline, then the wrong way round the splenic flexure. The scope then inevitably pushes down a deep transverse loop with acute angulation at the hepatic flexure. Whereas, by pulling back towards the splenic flexure and rotating strongly counterclockwise, using the phrenicocholic ligament as a fulcrum, the descending colon twists back laterally into its proper position and the scope passes in conventionally.